Welcome to Share MBC Matters video presentation titled Blood Test Results, Understanding Your Laboratory Test Report. I'm your host, Kate Vieira-Fitzer, the Metastatic Breast Cancer Program Director at Share.
And I'm Victoria Goldberg. I'm here to represent the podcast, our MBC Live, and I really wanted to meet and talk to Dr. Torres. And I just wanted to let you know that this recording is going to be turned into a podcast episode.
Before we begin, I'd like to tell you a little bit about Share. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecological cancers and provides outreach to the general public about signs and symptoms. Because no one should have to face breast cancer, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, our MBC Life podcast, a support group, our helplines, please visit our website at sharecancersupport.org. Now I'd like to hand it over to Dr. Alfredo Torres to introduce himself.
Hi, thank you, Kate, and thank you, Victoria, for having me here. Very excited to be part of this webinar and to reach so many patients. I think it's a wonderful initiative, and I wish you the best in your future endeavors. My name is Alfredo Torres. I'm a medical oncologist. I work at New York Cancer and Blood Specialist. I currently serve as the Assistant Chief Medical Officer. I have other titles. I work with the American Cancer Society on Long Island. I sit in their board as well, and I'm currently nominated as the Chief Chair for GI in One Oncology, which is a big umbrella group that we have for community practice. I'm certified as an internal medicine. I'm certified in medical oncology and medical hematology as well. One of the reasons we're meeting today is actually that we want to go over some of the labs that you will see as a patient, the labs that we commonly use for surveillance treatment of the cancer itself and also possible side effects that can be encountered with some of the therapies that we use, especially in the metastatic setting. So one of the things that has changed recently with the Transparency Act is that most of the patients have access to their medical information almost immediately. That in one hand is phenomenal because that will empower people to advocate for themselves in terms of knowing exactly what's happening and having that accessibility to their records easily. But it also creates a lot of confusion and anxiety because it's not just about what the lab and the number says, it's how to interpret it and put it in the right context. But the reality is that knowing when that value, if it's abnormal, is actually of clinical relevance, that becomes a little bit more challenging. But I'm hoping that during this 10 to 15 minute discussion, I can tell you at least some of the basic blood works that we typically see, so you as a patient can advocate for yourself in case you're seeing any abnormalities. I will say the most commonly used lab is the CBC. That stands for complete blood count. And here we are actually going to see three big numbers. The first one is the white blood cell. The white blood cell usually ranges from 4 to 10, and it can tell you a lot. When you're below that number, that's called neutropenia usually. And when those numbers are severely down, especially if your absolute neutrophil count, ANC for short, is quite low, you're running a risk of having severe neutropenia. And that makes you very immunocompromised, meaning that if you have a fever, it's quite an emergency, actually. You need IV antibiotics the sooner possible. When the white blood cell count is high, it could be that you're having an infection, but it also could be that you're having a normal response if you're having what we call growth factors. Sometimes when you're having chemotherapy, we give you an injection to avoid the neutropenia. And when those numbers are high, it could be a perfect natural response to the growth factors working. So again, seeing the number by itself doesn't mean anything. You have to put it in the right context. So that's in the white blood cell count space. Then the second big number that we address is the hemoglobin. So the hemoglobin in a normal woman will be 11.5 or greater. In a man can be a gram higher and also depends on the age. But a hemoglobin, when it's low, that's called anemia. The lower the hemoglobin, the more symptomatic the patient is expected to be. So shortness of breath, tachycardia, fatigue, headaches, pallor, being pale. All of those symptoms are expected with anemia. And the lower the number, the more of symptoms you will see. However, the anemia has to be interpreted if it's acute, meaning that it happened quickly. So you're having normal anemia and then suddenly you have a big drop. Usually when that happens, patients are way more symptomatic, and it probably has to do with either bleeding or a more severe reaction to chemotherapy. or if it's chronic, it's a more of a slow downtrend in the hemoglobin. They're actually not symptomatic. And I have seen both cases of a patient, for example, with a hemoglobin of 7 that is extremely short of breath, winded, and tachycardic, and a patient with a hemoglobin of 7 that is completely normal. Usually that happens when it's more chronic, so your body has time to accommodate. The last number that we see on the CBC is the platelet count. So platelets, as we know, is a cell that is in charge of helping with clotting, and that number can fluctuate depending if the patient is on chemotherapy. So that's for the CBC. As a hematologist oncologist, we look a little bit deeper into the subtypes of white blood cell count, but that could be a little complicated. But as a rule of thumb, if you know what's happening with the white blood cell count, the hemoglobin, and the platelet count, that gives you a very good overall about what's happening. The next test that we use is called the CMP, and that stands for complete metabolic profile. And the difference between the complete metabolic profile and the basic metabolic profile is the inclusion of the liver function tests. And we'll talk about them. In the CMP and the BMP, we're usually going to see the electrolytes and the renal function. The electrolytes that we see are sodium, potassium, chloride. Then we're also going to see the CO2 level, glucose, and the renal function test. The renal function test is usually presented as BUN and creatinine. And that will tell you how your kidneys are functioning. Very important to know that it can also be an indicator of dehydration. So for example, if you see a very high BUN with a ratio to the BUN to creatinine greater than 20, is suggestive of dehydration. And then sodium, potassium, and chloride, you can see them being high or low depending on certain situations, and they should be grossly within normal limits. In terms of the CMP, so complete metabolic profile, you're going to add the liver function test, LFTs for short. The liver function tests are going to be ALT, AST, ALK phos, and total bilirubin. And they're actually very helpful to see two things. The first one, if the liver is functioning well, and that could be because of therapy, chemotherapy, because again, a big portion of the chemotherapies are processed and metabolized by the liver. The second thing, breast cancer tends to go to the liver. Again, you have to put in the right context, but it could be suggestive of liver dysfunction by either therapy or the disease itself. You can also see sometimes if there's an obstruction in the biliary tract, so your bilirubin can get elevated. So with that, we can actually see a lot. And alkaline phosphatase, ALK phos, is something that is related to the liver and the liver functionality, but it also can be seen elevated in the setting of bone disease. So that's something that, especially in breast cancer, that tends to metastasize to the bones, we pay a close attention to. And then electrolytes that we follow there are calcium and magnesium. Calcium is important, especially if you're getting a bone resortive agent, so Xgeva or Prolia or Someta. Those agents need calcium to build up your bones. So you can see hypocalcemia if you're in treatment with those agents. Also, if the calcium is high, it could be an indicator that metastatic disease is going into the bones. And there's a thing called malignant hypercalcemia. So if the calcium level is extremely high, that could be considered also a medical emergency. Other tests that we like to order in breast cancer are vitamin D levels. We check them often. The majority of people actually have low vitamin D, especially when the winter comes, the sun exposure gets a little less. And I want to emphasize something very specific to breast cancer. We check what we call tumor markers. So the tumor markers are labs that can help us see if there's activity of the disease happening. And the important thing about the tumor marker is not necessarily the number itself, but the trend. And I like to share a story with my patients. I think that a lab actually is a picture. And we don't want to see a picture, something frozen on time. We like to see a movie. So to me, the number itself doesn't tell me quite the whole story. I like to see the trend. If the trend is going up, especially if it's going up rather quickly, there's a fast doubling time. That's actually very suspicious and very worrisome for activity of the disease. And the opposite is also true. If the numbers are going down, it actually tells you that the patient is responding to that therapy. When you're going through chemotherapy, because you are going through processes of losing a little bit of blood, decreasing the production, and then you're trying to ramp up that production in the bone marrow, we like to test for folic acid, B12, and iron levels, which are the main components of hemoglobin. So we check an iron panel ever so often. That iron panel will have the iron, the TIBC, which is the total iron binding capacity, which if it's high, that means that you're in need of iron. And we check the ferritin. So if the ferritin is usually less than 100, that means that you don't have enough iron. In terms of B12 and folic acid, if they're low, we like to replace because you are going to need those vitamins in order to make sure that you have a normal production of hemoglobin that will help to expedite the recovery of the anemia. So those are usually the main labs. If you're having a specific medication that can have some specific side effects, for example, we have some medications that can affect your cholesterol. We like to check a lipid profile every 3 months. Or if you have a medication that can affect your glucose, we like to check the A1C also every 3 months or every so often, depending on if it's controlled or not, to make sure that those labs are not getting out of hand. Again, the most important thing when we see these labs is actually the interpretation of where the labs are. Sometimes one doesn't tell you the whole story. Being outside of the normal ranges is not an indicator to panic or to be extremely concerned, but to have a fair discussion with your doctor. And with the exception of, for example, hypercalcemia and neutropenic fever, most of them are not an emergency. I tell my patients that treating and living with metastatic breast cancer is more like a marathon, not like a sprint.
When you were talking about normal range, you had mentioned grossly normal range. A lot of us in the community, we're trying to stay on top of our labs and we're looking at things, and they really honed in on the interpretation. And we should not be our own doctors and interpret this stuff. But there are so many questions when it comes to normal range. A lot of times we hear patients say, it's within normal range, but I'm seeing a trend and it's going up, or sometimes it's up and it's high upper range, and sometimes it's low lower range, and they're trying to analyze it. And what does that mean? It would be wonderful to hear your take on what a normal range is and what do you mean by grossly normal?
Absolutely. So you're not the doctor, you're not responsible to make decisions based on those numbers, but the more that you know about them, the better a conversation we can have. So what is a normal range? A normal range is exactly what the lab designs to be within normal limits. And usually those labs were determined when they study thousands of people and they did pretty much a bell curve, and you have a minimum and a maximum of normalcy on those lab values. You mentioned something very important. So just seeing normal ranges doesn't get you out of the woods, but most of the time it is okay to be within normal ranges. If you're hitting those normal ranges every time you get blood work, that's usually a good indicator that things are going to be okay and they're stable. But let's talk about some of the numbers in more detail, like you mentioned. So the white blood cell, we said usually a normal range will be like 4 to 10. If you're below or above, that's something to address. For the hemoglobin, less than 11.5, you're usually going to see that the patient is anemic. The lower the number, the more symptomatic and the worse it is. And then for platelet counts, for us in hematology, we pay more attention when the platelets are starting to be below 100. When they're below 50, we say, okay, we probably need to do some medication modification if they're taking antiplatelet therapy and anticoagulation. And if they're less than 30 or if they're bleeding, then we really have to address it, okay, with something else. That will be platelet transfusion or medication, depending on whatever the case will be. If you go on the CMP, usually when the electrolytes, sodium, potassium, are abnormal, we tend to address it. It could be something as simple if the sodium is low for the patient to eat a little bit more salt, or to hydrate better if the kidney function is a little abnormal. But in general, we want to address the electrolytes because when they're far away from the normalcy, they can actually have problems with the heart, and those could be serious. The renal function, the BUN, the creatinine I was mentioning, usually doesn't change drastically. And when that happens, that's something more acute that is happening, like an obstruction, for example, in the bladder or the urethra. The most common abnormal lab that we see is a difference between the BUN and the creatinine, and that usually is a sign of dehydration, which is seen after chemotherapy because of the inability to drink, maybe secondary to nausea. So I'm always emphasizing to my patients that you have to maintain adequate hydration after chemotherapy, and if they cannot achieve that, then I have the patients get hydration IV just to make sure that we're helping and preventing dehydration. It's not because of the number, it's because of how people feel. When you're dehydrated, then the side effects are usually worse. The liver function tests are very similar to the kidney function. They usually don't jump too high, and you have a lot of wiggle room because the liver is a very noble organ, and only with like 10% of the liver, it will still function well. So normal would be like 30 or less. But if you're seeing that 30 to 100, roughly speaking, you're still fine. There's not a lot of things to do. But if you're starting to see like the numbers being 3x, 5x, 10x, the normal limit of normal, that's not good, especially if it happens acutely. So that means that the liver is being overwhelmed either by a side effect from the medication, an infection, or disease. So that's something to pay attention to. For the tumor markers that we mentioned, the number itself doesn't mean much. Usually, depending on which tumor marker and which lab we are using, that number is usually less than 30, for example, for some of the tumor markers that we follow. If you're following CEA for a non-smoker, is usually less than 5. The number itself, to me, is not super relevant. It's the trend for that number that we actually follow. Vitamin D that we touch upon is usually 30 or above. If it's less than 30, you're actually low on vitamin D. And one important one will be calcium. The calcium is usually below 10. If it's greater than 10, it's dangerous. If it's below 8, that's also not good as well.
We had another question regarding the liver enzymes, because that's something that can sometimes go up, and we wonder, why is it going up? Is it the treatment that we're on? Perhaps maybe a dose needs to be changed, or maybe it's liver progression, because that's an area of concern for us with metastatic breast cancer. That something triggers and said, you know what would you do?
We don't treat numbers. We treat people. So if you give me numbers, cold and dry, and you show me a picture, I will probably won't be able to tell what's happening. But if you tell me more information, I examine the patient, I know their patient history, I might be able to have a better deduction about what's causing what. For example, if I have a patient that I know is getting a therapy that is actually metabolized by the liver, and the patient had normal liver function tests, and then the week after I give the chemotherapy, those numbers went up, I can almost assure you that that was a side effect from the medication. Now, if you're telling me that a patient has liver disease and has the liver function test slowly trending up and up and up and up, and then suddenly has a little bit more of a jump, and that patient is taking therapy that is not what we call toxic to the liver, and that patient, for example, the alkaline phosphatase is going up, and I do know that they have baseline liver disease, I will say, okay, this is probably more of the disease than the medication. When you have the two situations, when you have liver dysfunction because the patient has a baseline metastatic disease to the liver, but you also have a medication that is affecting the liver, you have to see when did the patient start the medication, what doses is the patient taking, and you have to see if the patient has any new medication that was included on their arsenal, even over-the-counter stuff or herbal stuff. I had a patient recently, she was taking a medication that was toxic to the liver, but she was doing great for months. The LFT suddenly had a jump, and I couldn't make a lot of sense out of it. So I started asking her if she took anything, and she actually went on a portal and saw there was a medication that she read was great for the therapy, and she didn't tell me. It was an over-the-counter medication, and her liver enzymes 10x from where she was.
Oh.
So I had told her not to take the medication. So you have to get the story, and sometimes it is hard, but we have other ways of complementing that information. We do physical exam. We ask you a couple of questions, which I highly value, and I think you get a lot of information. And then lastly, we actually can do imaging as well to see if we can sort out what's what. But again, on a patient that comes to me and shows me a lab result, only a lab result without anything else, will be a little challenging.
I just wanted to jump in for a second.
Yes.
You were using some acronyms that maybe people don't know what they mean, including me. LFT, I think the other one was AST. What do they stand for and what do they measure?
LFTs is a short acronym for liver function test. In the liver function test, you have what we call the AST and ALT. They're part of the liver enzymes. And there's another way of mentioning AST and ALT is GGT, which is also functionality of the liver. And you have bilirubin and alkaline phosphatase. The short way that we refer to is ALKPHOS as well. So those are what we call liver function tests. The AST stands for aspartate aminotransferase, and then the ALT.
We'll be using that on our regular basis. Thank you.
Oh, yeah. So that's what we shorten. And the ALT is alanine transaminase, by the way. We never use those names. We use AST and ALT for short.
I think we will stick to that as well.
Yeah, we will stick to those. That's a lot easier. So most of us, and I don't know if it's true for every regimen, but for people who are doing IV chemo and IV targeted therapies, we get our CBCs every time before the treatment. And I think People who are on a pill get it a little less often, maybe once a month. I wanted to ask you, the other tests that you had mentioned, how often are those prescribed? How often do you do the other two tests that you talked about? And should they be done on a regular basis or only if there is something wrong with the CBCs?
So CBC, which is complete blood count, and CMP, which is a complete metabolic profile or a basic metabolic profile, which is a CMP without the liver function test or LFTs, they should be done quite routinely, especially if the patient is on therapy. I will say in an active patient, usually once a month, we tend to run those tests. That's a gross estimate, but for some chemotherapies, you need to do it a little bit sooner. For tumor markers, every 3 months, it will be sufficient. For A1C, which is the hemoglobin glycosylated, which is the one that we use for diabetes or to see how the glucose or sugar is, the same as lipid profile, we tend to do them every 3 months if the medication that we're using can cause some reactions to the lipids, which is the cholesterol, or to the sugar, which is the glucose. I remember something that I wanted to communicate as well. Knowing the numbers and knowing what normal parameters is important, but I say more importantly, it's actually to know what to do with them. So for example, a lot of the medications that we give, they could be what we call nephrotoxic, meaning toxic to the kidney, or a lot of them could be toxic to the liver. So when we see the renal function test being abnormal, and when we see the liver function test being abnormal, if that's a consequence of the medication that we're giving, we have to adjust that medication. There's actually protocols that say you have to dose reduce the medication if you're seeing X or Y or Z organ being affected. And it's a job of the oncologist, but I want to make sure that people can advocate for themselves. They have to say, if my renal function is being compromised or my liver function is being compromised, is any of my other therapies, my hypertension medication, my diabetes medication, my blood thinners, do I have to modify any of them? And sometimes the answer is no. But I think it's very important for the patient to communicate with the doctor saying, listen, I think we need to revise my medication list, make sure that there's nothing that needs to be modified. Also, over-the-counter medications, even though you don't have to get a prescription and they could be deemed as natural, they can definitely modify your renal function and your liver function test. So before you start anything, just communicate with your doctor. You will be surprised that most of the people are willing to incorporate what we call holistics or alternative medication if they're not interacting or if they're not posing any threats to the patient.
So the key here is listen to your doctor, talk to your doctor, have an open communication. But I wanted to go back to the three numbers. We like numbers. The three numbers that seem to be the most important ones that we get from the CBC, right? Mm-hmm. And that's the red counts, the white cell counts, and the platelets. So I want to ask you about a topic that's very dear to my heart, the anemia. As far as I know, and correct me if I'm wrong, all anemia is not the same. There are different types of anemia. Can you go quickly over that so people would understand
Absolutely.
that not everything is related to iron depletion?
Correct. So as a hematologist, the first lab that we check when we have an anemia patient is the reticulocyte count. The reticulocyte count is the baby red blood cells. The way that I explain that is that when you have the bone marrow and you have to start ramping up the production to respond to anemia, because your body being so smart saying the hemoglobin is low, we have to ramp up the production, is going to spill like a couple of baby red blood cells into the bloodstream. That's actually good. When we see those numbers, when we see the reticulocyte count being high, that means that your bone marrow is working well. Mm-hmm. So when your marrow is working well, the anemia is usually secondary to hemolysis, which is an autoimmune phenomenon of your own body destroying your red blood cells, or bleeding. Sometimes you can bleed through the stool and not see it. The stool is normal and you can still be bleeding. So that is anemia, but with a normal functioning marrow. Now, going back to the reticulocyte count, if you don't see it in the bloodstream, that means that your marrow is not producing enough red blood cells. And when that happens, we check a second number called MCV. That stands for mean corpuscular volume. That is the difference in size between the cells, the red blood cells. So when the MCV is low, that's iron deficiency or a thalassemia. Those are iron deficiency, by the way, is the most common anemia. That's why people automatically reflect to thinking about iron deficiency when they see anemia, but it's not the only one. Now, when that MCV is normal, meaning that it's between 80 to 100, That is what we call normocytic anemia, and is usually secondary to anemia of chronic disease, more commonly renal dysfunction. And when that MCV is greater than 100, we call that macrocytic anemia. It's usually B12, folic acid deficiency, alcohol, and there's other diseases as well, like MDS, that could be part of that. So we use that to help us sort out what type of anemia the patient is having.
Thank you so much. You've explained it so well that now I actually understand it. But I have a question, and you mentioned that it's not about the numbers, it's about what to do with these numbers. So what do you do when you are anemic? As far as I know, and I might not be right about this, that the blood transfusion is the only way to fix it. Maybe not. And how often is it safe to do blood transfusions?
Absolutely. Great question. So the reality is diagnosis, staging, then treatment. I want to know why the anemia is happening. I want to see if I can fix that underlying issue, okay? And by the way, transfusions are not the only way that we can use for anemia. So I'm going to talk very basically. B12 and folic acid deficiency, you give vitamins. Iron deficiency, I'll give you iron. If you have problems with your kidney function, or if it's secondary to chemotherapy, I can give you an injection that is called EPO, erythropoietin analogs, that does the same thing that the kidney does to bring the hemoglobin up. Okay, so there's things that can be done, and there's more things, of course, but I just want to keep it a little short. Now, transfusions, if the hemoglobin is below 7, or there is vital sign compromise, meaning your blood pressure is too low, your oxygenation is going low, then that patient needs transfusions. Having a lot of transfusion is not necessarily bad, but we try to avoid it, because the more transfusions that you get, your body will start seeing a lot of antibodies, and then it will be harder for you to actually get compatible blood. So we try the best as possible within our means to avoid really low levels of anemia. If we have to modify the chemotherapy, if we have to dose interrupt, if we have to postpone one cycle and move it up a little, or if we have to give you growth factors such as like the one that I was mentioning for the kidney, the EPO analog, we can do all that to actually try to maintain a better level of hemoglobin. It is fairly normal to see a little bit of anemia. We call that mild anemia during therapy. So if your hemoglobin is 9, 10, you should be functional. You should be feeling okay. You are not in transfusion territory.
Okay, well, that's wonderful. It's good to know, because 20 years ago, when I had my early stage cancer, I told Kate that I got a Procrit shot at the time that they used to give, but I think they don't do it anymore, right?
We don't do it for early stage, but we do it for metastatic, okay?
Oh, I see.
And that is a very important topic. The reason for that is that there is some thought that in the early stage that can stimulate the growth of the tumor, but in the metastatic setting, actually, it's okay and it's approved. So that's a great question. So all the EPO analogs, including Procrit, are safe to use in the metastatic setting.
You talked a lot about communication and how important it is to have good patient-doctor communication. When patients see their results on the portal and they come back abnormal, what are the next steps usually on the oncology side? What do oncologists typically do when they see that?
In an ideal world, and we're not living in a perfect world, by the time that you get those results, we already went through them, okay, and they're publicly released. If there were to be an emergency, there are actually systems that are check and balances to minimize the possibility of any of those labs slipping through. So when we see them, we get alerted, especially if it's a critical lab. So there's normal, abnormal, and then critical. So when we have a critical lab, then we usually get notified and we have to address it right away. It is New York State law that whenever the lab releases a critical value, a doctor has to be notified, even if it's in the morning. And I know that because I'm on call sometimes and I get them. So I have to address it if it's critical. If it's not critical, we usually have time to actually sit down and review it. If we see you're having an appointment to come and see me soon, we can actually do it in person. If it's something that is still abnormal and needs to be addressed sooner, you should be expecting a phone call from your physician or the nurse. And whenever none of those things are happening, you always can advocate and call the number that you have to contact your physician office and ask them, listen, I'm concerned about this lab. Is there something that I need to address? Again, it goes back in full circle in terms of advocating for yourself. Medicine in the US is short staff, not just from a medical standpoint, but also nurses and front desk. And it is tough for us to handle the volume sometimes. So nothing is perfect. There's only one of you that takes care of you, and I have to take care of 6,000 patients. I do my best not to miss anything, but we're human. So always advocate for yourself.
We want to reiterate it again.
Yeah.
Advocate for yourself, but do keep an open conversation with your doctor.
Yeah,
Very
it's so important. Now, I do want to ask you specifically this question because we hear it all the time. We know that you're human. We know that oncologists are very busy. Communication is hard. Patients have questions, and sometimes they feel dismissed. The oncologist will say, "Oh, it's okay." So I always love to hear your advice on how a patient could maybe ask the right question to their provider so that they actually get the answer that they need and they don't feel that they're dismissed.
That's a very smart question. I think doctor and a patient, they have a relationship, and that relationship needs to be built. There's different personalities and different ways, but I think as a general rule of thumb, if you are polite and you ask politely and you say, I need to get an answer about X, Y, and Z, for example, doctor, why do you think that my liver function test is progressively getting worse? Every time that we check, the number keeps getting higher. I know that you mentioned in the past that it's normal, but why you might think that that's happening? I want to pick your brain. Saying an open question instead of saying, is this okay? Because if you give them an easy way out of saying, like, is this normal? Yes or no? The same thing we get in training for medical school. If we want to get information from you, I won't ask you a yes or no question. I will ask an open question. I'll say, how are you feeling? What has changed since the last time I saw you? If I want to get information, I'll do open-ended questions. So I think an open-ended question to your provider could be a solution. Why do you think this is happening? My fatigue has been getting worse over the past couple of days. What is the main culprit? Or what can I do to try to fix those liver function tests? Do you think that there's anything that I could be eating differently, or is something related to any of the medications? But open-ended questions, I think, is the way to go.
So much to talk about still, and liquid biopsy is on the top of everyone's mind. So if you're up to it, we would love to have you back, Dr. Torres. We want to thank you so much for generously sharing your time and your expertise with us today. We really, really appreciate it.
It was an honor sharing with you guys.